Good morning, ladies and gentlemen. The talk that I'm going to give to you today is entitled Moving Forwards Without Looking Back, and aims to relay findings from a sub-study nested within the larger V-Time project, a study which many of you will have participated in over the last few years. I'm going to start this presentation by giving you some background information as to why this study was developed. Recently there has been a shift in the goal of ageing research, such that previously the predominant aim was to add years to life by increasing life expectancy. We may consider that this aim has now been achieved, judging not only by the reports within the news and media, but also from recent predictions from Age UK, that the over 85 years age group will grow from 1.5 million in the UK to 5 million by the year 2050. Accordingly, the focus has now shifted from adding years to life to now adding life to the years that we have by prolonging good psychological and physical health and maintaining a better quality of life for longer. One of the largest contributing factors influencing reduced quality of life in older age is the incidence and prevalence of falls, which are increasingly common as we age and in people with Parkinson's disease. Falls become more common with age, but also as the symptoms of Parkinson's become more severe. The high risk of falls is in part due to age-related and pathology-associated visual deficits and gait impairments, which influence locomotor safety. Tripping and falls often occur during dynamic tasks such as walking and obstacle crossing, and as such, evaluation of these tasks in high-risk populations forms a large focus of falls prevention research. Tripping may be defined as an unintentional contact between the foot and either the floor or environmental object without successful balance recovery. Tripping accounts for 60% of all falls in older populations. During our daily lives, we are required to adapt our walking patterns to overcome a variety of obstacles that are different shapes and sizes. As such, this led us to ask the question, is gait and visual behaviour altered in response to obstacles of varying size? We picked 3 different sized obstacles shown at the bottom of the slide, a small, low and tall obstacle, all chosen to try to emulate some of the common obstacles which we encounter in our daily life. The contrast between an object and its background can affect our ability to perceive potential ground-based hazards. Changes in the time of day, interior and exterior design, and weather conditions, as well as impairments in visual function, are all factors that can reduce natural contrast within the environment. We were therefore also interested in asking if and how gait and visual behaviour was altered in response to obstacles of varying contrast. So we used the same 3 sized obstacles that I presented in the previous slide and covered them in a high and a low contrast material. This study was integrated within the larger V-Time study which Sylvia has just been talking about. A subset of people with Parkinson's who had previously fallen were recruited and participated. Participants underwent a variety of visual function and gait assessments prior to being enrolled in a 6-week intervention. We assessed participants' vision using eye charts similar to those you will have encountered at an ophthalmologist's or optometry department in your local hospital. We asked participants to negotiate a variety of obstacles that differed in both size and contrast, whilst their visual and gait behaviour was recorded. Participants were then randomised to either a treadmill training programme or a treadmill training programme augmented by virtual reality, which aimed to simultaneously train the visual, cognitive and motor control of gait. Participants then completed the same assessments that they did prior to the intervention, again post-intervention. And for the purposes of today's talk, I'm mainly going to focus on the pre-training assessments. So we measured gait by using a 3-dimensional motion capture system capable of recording movement of the whole body relative to space and time, a system which you'll hear more about in this afternoon's demonstration by Adon and Rosie. Firstly, small reflective markers are placed over anatomical landmarks of the body. High-speed infrared cameras are then used to plot the motion of these markers within a three-dimensional volume. The movement of these markers are then used to model the segments of the body, and in this case included the head, torso, hips and feet, and this information is then used to derive highly precise outcomes of movement. Whilst participants negotiated obstacles of varying size and contrast, we also measured their visual behaviour using a mobile eye tracker, which you'll also hear more about in this afternoon's workshops. Here we can see a video example of one of our students wearing the mobile eye tracker, which is placed around the forehead similar to a headband. The eye tracker is composed of two cameras, one that follows the movement of the eye and the other which tracks the visual scene within which the eye is focused upon. Participants in the present study were asked to begin the walking trial by firstly closing their eyes whilst an obstacle was placed on the walkway before them. Participants were then asked to open their eyes and make their way safely to the other end of the room. Participants negotiated one obstacle at a time whilst both movement and visual behaviour were monitored simultaneously. So the first question that we were interested in answering was how gait changed in response to obstacle size. Interestingly, we found that when crossing the small and high obstacles, people with Parkinson's widened their step considerably, thereby giving them a greater base of support and thus greater stability during a phase which poses a high risk for falls. However, we noted that this was not the case when crossing the long obstacle, which is shown in the centre of the slide there. As a result of lengthening their step, participants were unable to widen their step in the same way, which may leave this group at risk of mediolateral instability and consequently at a greater risk of falling sideways during the crossing of this particular sized obstacle. Thus, locomotor safety may be compromised when crossing a long obstacle in people with Parkinson's disease. In terms of visual behaviour, our preliminary analysis has revealed that participants spent a longer time looking at the tall obstacle, suggesting that visual attention was drawn to this obstacle, likely due to its prominence within the visual scene. When negotiating the small and low obstacles, participants spent a longer time looking at the ground preceding the obstacle, suggesting that when contrast was high, participants were prompted to search the immediate ground for other low-based obstacles that may pose a trip risk. The second question which we were interested in answering was if we manipulated the contrast and as such the visibility of ground-based obstacles that pose a high falls risk, would gait be altered in response? We observed that gait was modified when negotiating the low contrast obstacles, such that people with Parkinson's slowed down in their approach, thus prolonging the motor planning phase prior to the obstacle. They also took a longer step for the low obstacle when obstacle definition was reduced, and when contrast was low for the obstacles, participants widened their step as a function of obstacle size, so they widened their step for the long obstacle compared to the small, and for the high obstacle compared to the long obstacle. When comparing the visual behaviour in response to obstacles of varying contrast, our preliminary analysis revealed a change in visual behaviour, such that many of the participants spent less time looking at the low contrast obstacles, and as a result they may pose a greater risk of trip-related falls. This has implications for older populations for whom the ability to distinguish objects in the foreground from objects in the background may be reduced due to age-related and pathology-associated visual deficits. And by increasing the visual contrast of objects that pose a high risk of falls for older populations, it is possible that we may redirect visual attention to task-relevant stimuli. In conclusion, this study has shown that obstacles of varying size and contrast pose varying challenges to people with Parkinson's. We've shown that gait is altered in response to obstacles of varying size, with both the long and tall obstacles presenting considerable challenge to people with Parkinson's disease. We have also demonstrated that improving the contrast of task-relevant stimuli offers the potential to prompt gait alterations by promoting visual scanning and increasing visual attention to the task-relevant stimuli, which may help to reduce falls risk. The next logical step for us to take to develop this area of research is to begin to design and evaluate bespoke interventions appropriate for different faller groups, targeting trip hazards that pose the greatest risk. Thank you very much for your attention.